prehabilitation, and my aim is to implant an awareness into you, into the topic of prehabilitation, and upper GI cancers are ideally suitable for prehabilitation because, Shailesh, you are smiling. Because these patients have a great degree of malnutrition, they have sarcopenia, and the best thing is you have a hiatus, because many of these patients go for chemotherapy or radiotherapy, so you have 4 to 6 weeks to institute a prehabilitation program in these patients. How does prehabilitation possibly help? There is evidence that it improves the patient's post-operative physical performance, whether it reduces pulmonary complications, ICU stay, length of stay or readmissions is still debatable, but definitely prehabilitation does not alter mortality. And there are some topics which are discussed more often. In theory they'll sound very good, but practical outcomes are not there, and prehabilitation is one such topic which is being discussed, but if you see there any palpable benefits, one really does not know. We've been very interested in prehabilitation. We have a couple of studies. This is one of the recent studies we published in World Journal of Surgery, where it was these patients were not randomized patients of upper GI cancer who were resectable. We didn't select these patients. We offered prehabilitation to all these patients, and we emphasized a home-based program where patients were given an exercise schedule. They were asked to take a protein intake. The psychological counseling, I must confess, was more like a kitchen table philosophy, me talking to them. We do not have a... So there were about 100 patients. We divided them into 2 groups. Patients who completed their prehabilitation program, which was, like I said, a multimodal program. And there were group B of the patients who did not comply. So we try to compare these patients. And our primary endpoint to see in these patients was post-operative pneumonia, because we know beforehand that if you are looking for any meaningful alteration in anastomotic rates or length of stay, that's not going to happen. But that was a secondary endpoint. And that's what the results showed, that the only statistically significant thing which came out in our study was that the incidence of chest complications was lesser in those patients who completed the prehabilitation that we had prescribed to them. When we did this study, we realized the barriers to implementation of prehabilitation. It's easy to talk, but if you really want to see, there are a lot of barriers. Most Indian patients are psychologically averse to exercise. They have numerous complaints they don't want to do. They have never exercised in their life. There are financial reasons, because affording a commercially available protein diet is difficult for them, and there are social reasons. And interestingly, we realized that men were more compliant than women were, not because men were better, because mostly the wives supervised better for their husbands, but when it comes for a husband to supervise a wife, it rarely happens. So women suffered, the mothers did better for their children, fathers rarely did anything for their children. So that's the skewed thing. So women contribute more to the participation of an individual in prehabilitation. It's still not a popular concept because most of us are unfamiliar. We do not believe. When a patient comes to a surgeon, the surgeon quickly wants to operate because he's scared that the patient might go to somebody else. So you get the patient in and operate quickly and don't want to institute prehabilitation. Makes sense. And the second biggest thing is we do not have a uniformly available protocol. What is a possible in West may not be possible in India. We don't have treadmills. So we ask patients to go upstairs. So we have problems like that. And the literature also, like I said, does not give adequate proof that it works. The number of patients are less, the data is heterogeneous, and also our goals are undefined. If we are looking to alter mortality or to decrease anastomotic leak rates, we'll need a large number of patients, and that is not going to happen. There are a lot of unanswered questions in prehabilitation. How much is the minimum time which would be there to institute meaningful prehabilitation? At least 2 weeks are needed. before we can give any meaningful alteration to patient outcomes. What is the best exercise? Should be spirometry, should be resistance exercises, how to go about it. How do you ensure compliance? We believe we gave our patients some diaries to write something. How are we so sure that what they did, they really did? Well, because it is so expensive. So all these questions needs to be answered. The unanswered question is, how does multimodal prehabilitation work? There are a lot of studies about various hormonal changes, various psychological aspects, and I believe one of the way it works is because the surgeon also feels better when he's operating that this patient possibly has received prehabilitation. So surgeon himself also gets biased. And the big question to my mind is, are all patients candidate for prehabilitation, or should we do some screening tools to find out in which patients prehabilitation is going to work? What are the areas of future research? We are currently working on a small study where we are using probiotics and some symbiotics, because there is a lot of evidence today the gut flora alters outcomes, so possibly using some probiotics might alter. And how does adherence to prehabilitation affect our ERAS protocols, and what is the long-term effect of survival? Because one of the factors which have been found to long-term survival in cancer patients is the persistence of muscle mass. Some of our patients tell us that even after surgery they got used to doing some degree of exercise. So in long term, to assess how does prehabilitation improve long-term survival in cancer is also an important issue. Thank you very much for giving me this opportunity.